Hello, everyone. I am Rahul Gosain.
And I'm Rohit Gosain.
And we are Oncology Brothers. Just days ago, close to 6,000 abstracts were presented at ASCO 2023, focusing on what is practice changing or informing in breast cancer arena. We've selected 3 studies: NATALEE Trial in adjuvant settings, and then Sonia Trial and X77 in metastatic space. To go over these critical studies, we're joined by a renowned breast medical oncologist, Dr. Stephanie Graff. Dr. Graff, welcome.
Thanks for having me. It was great to see you guys at ASCO, and it's great to be here again with you today.
Yes, it was certainly nice meeting everyone. That's the best part about ASCO, and learned so much. Wow, what a weekend it has been. I feel I'm still in daze from all the data that was presented at ASCO 2023. To get started, we're going to jump into NATALEE Trial. But before we get started with that, it is important to establish and discuss what is the current standard of care. That is abemaciclib in early hormone receptor positive patient population in adjuvant setting in high-risk patients. Now, abemaciclib data was also updated at ASCO 2023, where we saw the benefit in less than 65-year-old patient population and above 65-year-old patient population. And then importantly, patients who had dose reduction also had sustained benefit. Now, we have data from NATALEE Trial looking at ribociclib in adjuvant setting. Dr. Graff, what was the study design and the inclusion criteria here?
So the NATALEE trial randomized patients with early stage breast cancer to ribociclib in combination with hormone therapy versus hormone therapy alone. The hormone therapy that was used was the nonsteroidal aromatase inhibitors, so only letrozole or anastrozole. Premenopausal patients or men had to have ovarian function suppression in order to be considered eligible. And it was a 1-to-1 randomization scheme. Now, the NATALEE trial, importantly, has slightly broader eligibility criteria than monarch-E, so it's a slightly lower risk population. In short, monarch-E took patients that had N2 or N3 disease, and a small population of patients that had N1 disease and additional risk factors. T3 tumors, grade 3 tumors, or a Ki67 of greater than 20%. NATALEE took all N1 disease, also all N2 and N3 disease. NATALEE also took some N0 disease, specifically T2N0 disease, and then anybody that was stage 3, even if they were stage 3 with N0 disease. If you were a T2N0, you had to have another risk factor, and that included either a grade 2 tumor with a Ki67 of greater than 20%, or a grade 2 tumor with a high-risk oncotype score, or other high genomic risk model like a mamma print. And so you had to meet one of those criteria in order to be eligible for NATALEE. Primary endpoint was invasive disease-free survival, and we showed that the reduction in invasive disease-free survival was an absolute reduction of 3.3% and a relative risk reduction of 25.2% after the median follow-up. Now, this is similar to what we'd seen in monarch-E at about the same time point. Of course, the dangerous cross-trial comparisons, we don't do that. Long-term, of course, I think that I agree. Dr. Nadia Harbeck was the discussant, and she ended her discussion by saying that she thinks this creates 2 standard of cares for the early, the adjuvant treatment of early stage breast cancer. I agree with that sentiment. Of course, now we get into that nuance in our clinical care of patients. For me, I will pay attention to who would have been eligible for monarch-E versus who would have been eligible for NATALEE. for patients that are in that Venn diagram of overlap that are eligible for both, I'm going to be thinking about things like the maturity of the data and how much that might matter to the patient that I'm sitting with. There's some patients that's an important factor. The side effects of the two drugs, the drug-drug interactions of the two drugs.
Thank you for going over that. Just to reiterate, it is so important to see this where we are starting to use lower doses rather than chasing the highest dose when we know there could be benefit. And again, focusing on quality of life is so critical in metastatic and, of course, adjuvant settings. And we continue to see this. But as a general medical oncologist, Dr. Graff, you've touched upon this on your end as well. Now we're seeing different doses being approved for different things, for different recommendations. It is so important for us to keep on top of that, not only the drug approvals, but also the drug dosing day in, day out when we're seeing these patients.
Yeah, and it's, it's really hard if you don't have a good mechanism to sort of double check yourself every time. I believe that's why there's so many checks and balances in what we do.
And just to add there, in ribociclib, we are using the therapy for a total of 3 years, while abemaciclib is 2 years. And I can't reiterate that we need to all be involved, including the patient as well.
Yes, exactly. Oh my gosh, so many nuances, right?
Yeah, at least in my practice, I anticipate that for node negative patients, of course, we'll favor RIBO, but for node positive disease, there's going to be a lot of discussion in terms of the side effects, what agent, and what's the right drug for the patient in front of us.
Yeah.
So this study, again, was in early breast cancer settings. Now let's switch gears and focus on second study, which is in metastatic hormone receptor positive patients. The current standard of care for these patients has been CDK4/6 inhibitors with AI. But this study challenges that selective few patients can get AI alone. Dr. Graff, can we start off with the study design and then we'll dive into its findings?
Yeah, so the Sonia study is a very well-designed, very pragmatic study conducted and funded by the Netherlands to ask, what should we be doing about sequencing? Does everybody need a CDK4/6 inhibitor in the first line? It took all patients with metastatic hormone receptor positive advanced breast cancer without evidence of visceral crisis and randomized them 1-to-1 if they had no prior therapy for metastatic breast cancer to either AI plus CDK4/6 inhibitor followed by fulvestrant, which we're going to call the standard of care arm because that's what our current practice is in the United States, versus first line aromatase inhibitor followed by fulvestrant plus CDK4/6 inhibitor. And what we see is that the primary endpoint of this study is what they have labeled PFS2, which is the progression-free survival after the switch. Overall survival is neutral, right? The median overall survival shows us that patients that got a first-line CDK4/6 inhibitor had a median overall survival of 45.9 months. Patients who got a second-line CDK4/6 inhibitor had a median overall survival of 53.7 months. The hazard ratio is, crossing the magical threshold. The two-sided p-value is 0.83, and these lines are not all that different. And so this is considered neutral. Notably, the PFS1 did show that patients did pretty well with a first-line CDK4/6 inhibitor at 24.7 months. But they also did really well with the first-line aromatase inhibitor, which is maybe a little bit more than what we would classically expect. It's hard for me to know if that's related to the homogeny of the Netherlands population versus the global populations that have been accrued to the CDK4/6 inhibitor studies. Additionally, the CDK4/6 inhibitor used in this study was by far and away palbociclib. Of course, we know that ribociclib has met overall survival. Abemaciclib is dangerously close, trending that way, and palbociclib did not meet its overall survival endpoint. So how the fact that palbociclib is the CDK4/6 inhibitor factors into our interpretation of this data is unclear. As I interpret this data, when I kind of take a step back and do the math, I think that patients who got a first-line CDK4/6 inhibitor also did really good on fulvestrant as a single agent. So there's lots of things that are just different about this trial and this patient population than that maybe translate to what we're seeing today in our US populations. Additionally, I would say that the second line standard of care right now arguably is not fulvestrant. We do genomic sequencing. So I don't know that to say that CDK4/6 inhibitor followed by AI versus AI followed by CDK4/6 inhibitor is really what our options look like today. So on the grander scheme of things, this is a complicated study to interpret in the context of American healthcare. I think that the Sonia trial is important. I think it's hard to put into play in the US.
And again, I don't think this by any means, at least here, changes our standard of care in first line, but certainly a food for thought saying, sequencing versus is it all just different CDK4/6 inhibitors, which of course is a conversation on its own. So
yeah.
As we're discussing metastatic disease, this is a good segue into our next study, X7.7, looking at capecitabine in our metastatic breast cancer patients population. Dr. Graff, if you don't mind walking us through the study design here.
So this study, X7x7, was led by Kumar Khan, who's one of my mentors, and I'm so proud of him in this work because it's, again, such a pragmatic study that just needed to be done, right? Of course we needed to know this. And it took patients with metastatic breast cancer of any biology, hormone receptor positive, triple negative, HER2 positive patients received the CAPE with trastuzumab. And patients were randomized 1-to-1 at any line of treatment, whether they, first, second, whatever, to either fixed dose capecitabine or standard dosed capecitabine. They were stratified by very rational things: the type of breast cancer, the line of chemotherapy that they were on. So we have very matched cohorts in a very heterogeneous population, which I think is important. Fixed dose capecitabine for this population is defined as capecitabine at 1,500 milligrams, full stop, not milligrams per meter squared, milligrams, PO twice a day for 7 days in a row, followed by a 7-day break, so every other week. The standard dose is described as capecitabine 1,250 milligrams per meter squared. Did you hear it? Twice a day, 14 days on, 1 day off. So patients, what we saw as we moved into the results, that received the standard dose as compared to the fixed dose, patients had very similar progression-free survival. Dr. Khan did do a landmark analysis where he assessed that the progression-free survival at 12, 24, and 36 months. And the fixed dose over time shows it favors the fixed dose. So patients stay on the fixed dose longer. Patients that were on the fixed dose had a much lower toxicity, which was actually stark. And dose reductions were also much, much more common in the standard dose set. Now, I want to comment here that, of course, this was all a metastatic population. I do not think that this extrapolates to using capecitabine in the CREATE-X population. But overall, I think that this X7x7 trial is practice changing, or at least practice informing. Do I think that every patient should get fixed dose capecitabine? Maybe not. Do I think that you can feel very comfortable altering your capecitabine dosing, particularly in patients that you are otherwise concerned about, and give them this fixed dose? Absolutely. To Dr. Khan's point, as he was introducing the concept, of course, the long legacy of medical oncology is that we just do drug discovery based on maximal tolerated dose, not maximal efficacious dose. And so it's been long unclear what dose of capecitabine actually works for breast cancer. And this has shown that a lower fixed dose of capecitabine appears to offer good efficacy.
Again, coming back to the same theme, we're seeing lower doses. We talked about this for RIBO, abema, and now here for capecitabine.
This is definitely kind of practice. This will change the way that I prescribe capecitabine. I will be more lenient on my dosing.
And additionally, to add to this is the side effect profile, which is diarrhea, hand-foot syndrome that we continue to see. And just to dive in, which was also presented, DTORCH, which is again, small changes, rather nominal cost changes, where utilization of topical diclofenac reduced the amount of symptoms that these patients were incurring.
Yeah, I completely agree. So DTORCH looked at diclofenac gel. The prescription was 1 gram, 1% topical gel, BID, so twice a day on your hands. Presumably you could apply it to your feet, but the trial was to your hands for the first 4 cycles and it showed a significant reduction in the risk of hand-foot syndrome. And a significant reduction in the rate of capecitabine dose reductions as well. So I agree. I think that that's practice changing. What an innocent intervention to offer somebody. And I think I mentioned, or like low attention poster that I thought was interesting was there was a poster that showed that taking tamoxifen at night rather than in the morning significantly prolonged disease-free survival with a hazard ratio of 0.43. Certainly, I don't think that what an easy intervention, right? To tell your patients to take tamoxifen at bedtime instead of in the morning. And I think all of us sometimes try that to get people's side effects to change anyway. So food for thought. Only worked with tamoxifen, not the AIs, but switching it to nighttime dosing for tamoxifen also seems like low-hanging fruit to make a potential intervention in the outcomes of our patients.
Absolutely.
And this is not just quality of life, this was rather survival, which is very impactful.
Yeah.
Dr. Graff, thank you so much for taking the time to go over these critical studies in breast cancer that were presented at ASCO 2023. To say the least, some of these are certainly practice informing and practice changing. Stay tuned for a quick summary and take-home points. Dr. Graff, thank you so much again. We just wrapped up our interview with Dr. Stephanie Graff, where we covered 3 important studies: NATALEE Trial with ribociclib, X7x7 evaluating the frequency of capecitabine, Sonia Trial looking at sequencing of CDK4/6 inhibitors. Question becomes, how are we planning to incorporate this data in our practice tomorrow?
So first, NATALEE Trial, we have to wait on the approval to come, which is very likely to happen. But this will give us an option of using another CDK4/6 inhibitor, ribociclib, in select node negative and beyond when it comes to breast cancer, which again is a broader indication than the current abemaciclib approval.
Agreed. Well, we have to keep in mind some nuances here. That is, ribociclib was utilized for 3 weeks on, 1 week off at 400 milligram dosing, which is different from metastatic setting, which is 600 milligrams. And here, the dose was utilized for a total of 3 years' time. In Monarch E, abemaciclib in adjuvant setting, one is to take the medication daily for a total of 2 years' time, and both of them have a different side effect profile.
Absolutely. And then X7x7, where we used a fixed dosing of capecitabine, 7 days on, 7 days off. This was better tolerated than the current standard dose that we tend to use for capecitabine. This study did not compromise outcomes, so patients tolerated the treatment better and had similar outcomes that we tend to see with standard of care.
In conjunction to this, with hand-foot syndrome, which we often see with capecitabine, a study DTORCH showed that topical diclofenac improves the side effects, especially hand-foot syndrome, significantly.
Absolutely. And then we've also covered Sonia Trial, where we saw that selected patients can maybe just get AI alone. That selected patient could be a frail patient who's sitting in front of you. But again, to reiterate, right now, this perhaps does not change the current standard of care of CDK4/6 inhibitors and AI in frontline settings.
Well, that's a wrap. Stay tuned for more next time with Oncology Brothers.